Nicola Normanno. I'm the president of the International Coordinator for Pathology and also the scientific director of the Istituto Tumori della Romagna, East in Meldola, in Emilia-Romagna. Well, the state of the art is that thanks to precision oncology, now we can distinguish in these tumor types a number of subtypes of tumors which carry specific genomic and molecular alteration for which we have available very, very active drugs. So basically in both lung cancer and breast cancer, now it's mandatory to perform molecular profiling of the tumor before deciding any line of therapy. This is in particular for patients in advanced cancer, because we have so many options, and thanks to molecular profiling we can better define which is the best therapeutic option for each individual patient. Well, basically we can do using different approach. One is through NGS testing of tumor tissue. So we use a small amount of tissue, we extract the DNA and RNA, and we make molecular profiling. Or we can use the liquid biopsy, which means the analysis of the circulating tumor DNA that is shedded by the tumor in the blood flow. Both these tests provide complementary information, but for example, in some instances, liquid biopsy might be better than tissue biopsy. This is in particular when patients are progressing on therapy and you want to identify resistant mutations such as T790M in lung cancer patient progressing on treatment with the EGFR receptor tyrosine kinase inhibitor, or ESR1 mutation in breast cancer patients who are progressing on endocrine therapy. In that case, liquid biopsy could be the first option because actually it is faster, it's less invasive, and also provide a better picture of the tumor heterogeneity. And by using liquid biopsy, we can identify this mutation and put patients on very active treatments. Well, MRD is a minimal residual disease, the detection of circulating tumor DNA after surgery or any intervention for the radical intent. So basically we know that after surgery the majority of patients are cured. However, there are some patients that will have recurrence of the disease, and this is due to the fact that some residual cells are still present in the patient. Now, using liquid biopsy, we can detect circulating tumor DNA. It has been demonstrated that those patients that are ctDNA positive after surgery have a much higher risk of recurrence as compared to patients who are MRD negative. So now the hypothesis is that using MRD test, ctDNA test after surgery, we can better stratify patients and decide who are the patients who should receive an adjuvant therapy after surgery, those who should not receive adjuvant therapy, and maybe also identify patients who should receive a more aggressive therapy. So it's still, I would say, an experimental tool, provides very important prognostic information, but I think that in the future we'll use a lot this tool to decide which treatment to give to our patients, also in this patient with early cancer. Quite expensive, I would say, because now the technology is in the hands of few companies. It is approved in the States for colon cancer, and I think also for other tumor types. In Europe, not yet, but the approach in Europe and the States is different. In the States, you approve a drug, we approve a device, and then if your insurance is paying for it, it's okay, otherwise, you will not get it. In Europe, once we approve a new device, a new drug, then we have to give to all patients. So that's the difference. And so I think that MRD is not the only answer, but it is an additional tool that's very important to make therapeutic decisions. We have to define which are really the area, the fraction of patients in which we really need this tool. And I think also we need some prospective clinical trials to demonstrate that by using MRD, we can better handle patients, and at the end, we can improve the survival of the patients.